Hello and welcome to Chapter 12, Week 4, Pharmacology. This chapter involves the conditions of arthritis and joint pain. So we're going to look at some common or relatively common conditions and how we manage them and treat them. In this chapter, we're going to be looking at three of the most common types of arthritic and joint pain disorders. Certainly, rheumatoid arthritis is a major one. It's inflammatory. We'll break it down. We'll also look at gout, which is an interesting one from a metabolic side of things. And then lastly, a generic form of arthritis known as osteoarthritis. So we're going to look at all three of these in this lecture. All three of these disorders, rheumatoid, gout, and osteo, all have aspects of inflammation. It's just that what they're doing is driving inflammation from different directions. So they're all going to have issues of heat and redness, occasionally swelling, certainly pain. Pain's the main one, but that pain may also lead to or exacerbate any loss of function associated with the inflammation. So all three disorders have that same property of driving inflammation. And as you move through your careers, you're going to see that inflammation and inappropriate levels of inflammation are often the commonality when it comes to disorders and pathology in your experience. We're going to start off with probably what's the most complex of the arthritis type disorders, and that's rheumatoid arthritis. What's happening in an overview, if you will, with rheumatoid arthritis is that you're getting selective inflammation on the inside of the synovial capsule and or the articulating joints. It's mediated by antibodies and antigen complexes driving chronic and persistent inflammation. So what we see is an eventual response in the tissues. The tissues begin responding, they begin changing their function, they begin growing separately, modifying and changing, and that's the basis of the rheums in rheumatoid arthritis. But it involves not only fundamental inflammation, it's also going to involve white blood cells and again the modification, the hyperplasia, dysplasia of the rheumatoid is the major differential characteristic from, say, osteoarthritis. Because you will almost certainly experience some level of rheumatoid arthritis in your personal lives, whether or not you're involved in geriatrics in your career, it's good to understand how the disease progresses. So here up in the upper left corner, we have a healthy joint. We have the synovial capsule that has fluid that's designed to actually limit inflammation. It's there because you have sliding surfaces. And almost anywhere in the body where we have major episodes of surfaces moving across each other, we have liquid surfaces. We can see this inside our lungs. We can see this in our heart, in the pericardium. You can see it even in the viscera, in the digestive tract. Never mind the joints. So you have these capsules that are designed to help limit inflammation, but that's the issue. The inflammation is actually localized into those areas. So here we have the initial stage. We have an inflammation of the synovial fluid. So what's happening is antibodies and antigen complexes are forming in this area, and it's triggering nonspecific inflammation in this area. And so initially you might have some mild pain, maybe hard to discriminate between this and, say, osteoarthritis. But what you have is inflammation. So you're going to start to see the joints begin to get larger than the surrounding bones. You might see, wider. Now, some people have this. Like, for instance, if I look at my hands right now, all my life, my finger joints have always been a little bit wider than the actual shafts of the bones. That's not synovitis, but if somebody has a change in those diameters, that's an early sign. What ends up happening is as that inflammation persists, the osteocytes in the cell begin to get stimulated by the cytokines, and they begin shifting to osteoblasts, or class, what happens is the bone cells begin changing their basic functions, and they begin depositing material in response to this inflammation. Inflammation can be a wonderful benefit in the short term, but in the long term, it's pro-mitogenic, and it is pro-formation of additional tissue. So any place where you have chronic inflammation, you begin to see remodeling of that tissue, and that's exactly what's happening in the stage 2 here, the pannus. That's where we lose cartilage, and we're beginning to have bone deposition, osteo deposition, and hardening of this entire area, rather than just inflammation, which is painful enough. Now we have tissue that's grinding against. You've lost some of that barrier, and now bone, which can have significant pain receptors in it, begins to grind against itself. In the later stages of rheumatoid arthritis, in 3 and 4, the remodeling gets to the point where you begin depositing connective tissue. That's that mitogenic response. If you saw this in the lungs, what you would see is that the lung begins to form cysts, okay? You begin to get these sort of cysts of connective tissue trying to wall off usually what's a pathogen like tuberculosis. That's an example of where the lung is trying to wall off that pathogen with connective tissue, and it's just happening here in the joints. We can actually begin to see a loss of mobility. You see stiffness and complete loss of function in those articulating surfaces, to the point where if left fully untreated for an extended period of time, the bones themselves will fuse. And here we have just a picture. You can actually see here some varying degrees of severity of disease. Like for instance, these fingers over here are relatively normal. There's a little bit going on here and in here. The thumbs you can see are relatively unaffected, maybe just a little bit, but look at the severity of the rheumatoid situation. That's where that's the rheums that we talk about. If you were to look at the fingers, you would see that there's a lot of swelling going on. If you look at, you can almost see it here. You can see this finger. If you look right here, you can see the swelling relative to this finger over here. That may or may not be an artifact, but it certainly looks suspicious. We can look at the swelling on this one relative to this one. So these fingers are relatively normal, and you can see the severe situation, the remodeling, if you will, of the joints over on the right side. Some key aspects of rheumatoid arthritis in terms of demographics and risk factors. If osteoarthritis is a disease of the aged, age is very much a risk factor, and it increases with age. In the case of rheumatoid arthritis, we see a young onset arthritis between the ages of 35 and 50. So we begin to see osteoarthritis in very, very young patients relative to say, osteoarthritis or other forms of arthritic disease. Women, for some reason, are 3 times more likely. We see 3 times as many patients who are female than male. Some other risk factors, there is a genetic part of this, and that's probably in the inflammatory side of the equation. Yes, age is a risk factor, but it's an age window. So if you get past 50, your likelihood of developing rheumatoid arthritis goes down. Obesity and lifestyle exposure to pollution. It turns out that folks who worked at ground zero during 9/11 have a higher incidence of rheumatoid arthritis. And there are comorbidities associated with rheumatoid arthritis. We tend to see rheumatoids in very specific locations. We see a lot of folks that have foot issues. That could be, again, back to lifestyle and occupation, certainly in the hand and the wrist. Other places are less common. The way we manage it is a good balanced lifestyle. It's hard to underestimate moderation in all things. That is to say, yes, you can have, that steak and potatoes if you love it, but you shouldn't have a cheeseburger every day. Eat across the rainbow. Try to get daily exercise that manipulates the joints. It's not enough just to walk. You want to walk and you want to do things with your hands. You want to do things with your arms. You want to get whole body exercise. Yes, there are drugs and certainly the other factors that are very much involved in limiting. So early detection is a big one because we really don't have a cure for this disease, and active management when somebody is experiencing whatever level of the disease. This is just showing you where we see the initial symptoms. And you can see a big one is hand and wrist pain. So almost, more than 2/3 experience or notice hand and wrist pain. Fatigue, stiffness, knee pain, these things fall off. But what we see first and foremost is that hand and wrist pain or fatigue and stiffness right in there. So if you're working with somebody who you consider to be at risk, that might be something that you're going to want to keep your eye on. Again, just like you guys can be the eyes and ears when it comes to ADRs and ADEs, you can be the eyes and ears when it comes to chronic disease. That's the beautiful thing about your choice of profession, is that you're going to be spending time with these people, and you can spot these things earlier sometimes than the patient might spot themselves. As a disease of inflammation and a disease of debilitation, there are significant comorbidities associated with RA. Roughly, more than a third, 35%, will experience one or more of these comorbidities associated, most frequently hypertension. And whether it's a hypertension driven by the RA itself or driven as a complication of RA because of the change in lifestyle and the stress, the pain, chronic pain is a very, very stressful initiating it, never mind just the endogenous activation of the sympathetic system. There's a significant psychological induction of the sympathetic system. Heart disease, diabetes. These are kind of the big three: hypertension, heart disease, and diabetes. But almost, at least a third of the patients are going to experience some form of comorbidity. And that's why disease management is so important. You may recall our discussion about types of hypersensitivity in previous lectures, where we have type 1 is anaphylaxis, IgE, cytotoxics is sort of tissue-specific reactions, 3 is autoimmune and complexes, and lastly the delayed type hypersensitivity in type 4. What we're seeing with rheumatoid arthritis is what we call a type 3 autoimmune. That's not to say that we don't see aspects of type 2 and type 4 in this. We can never really divorce ourselves. These categories are fundamentally, while somewhat accurate, are somewhat arbitrary as well, and they do interconnect. So, but what we're primarily believe is going on in rheumatoid arthritis is an immune complex type rheumatoid arthritis or inflammation, hypersensitivity of autoimmune antibodies inducing inflammation. And here are again the breakdown here. What we see is antibodies that are binding to autoantigens and then triggering inflammation. So a type 3 right here. That doesn't mean it's not inducing some type 4 stuff or triggering some type 2 stuff, but it's certainly in this realm. Now this was originally a larger poster, so it's a little bit tough to read, but it does summarize the basic pathogenesis of RA. That is that we have these complexes of antibodies that begin binding to the tissue in the joints, triggering signaling through reactive oxygen species, triggering the release of interleukin-1
and then TNF alpha that leads to inflammation and pathology. These are sort of the keystone molecules that we see in this disorder. So you have antibodies that trigger macrophage and cell-mediated responses, IL-1, TNF alpha, and ROS. TNF stands for tissue necrosis factor, which it was originally, thought to do that, but it's a carryover name, and it's one of those things I wish they would change the name for. What made TNF and its corresponding receptor such an attractive target in rheumatoid arthritis is that when scientists were studying synovial cells, so from patients with rheumatoid arthritis, they found that when they blocked TNF alpha, they identified that there was a receptor here and the TNF alpha was involved. When they were able to inhibit this, they found that the effects were more global. They saw suppression of IL-1 and IL-6 and IL-8 and other cytokines, more so than blocking other ones. And so the thought was that TNF was serving as some sort of a keystone leading to things that inflammation and responses in the synovial joints around the body.
One of the reasons TNF alpha is such an attractive target for therapeutic intervention in rheumatoid arthritis is the fact that it's going to activate other interleukins that lead to some of the symptoms, in particular IL-6, which is a degradation type interleukin. IL-6 is actually one of the more insidious ones in cancer that some of the tumors over-secrete or exogenously secrete IL-6, and that leads to a systemic type of wasting. But here what we're talking about is a localized situation. So IL-6 in particular. So what TNF is trying to do, or what by blocking TNF, what you're trying to do is you're blocking some of the downstream effects. So that's why it's an attractive target. And this can be illustrated in the table in your book. If you look at TNF, what you'll see is that there's a high amount of TNF and it leads to a lot of tissue damage. And that's why, interleukin-1 beta is a little bit problematic in terms of targeting, but TNF is a very, very attractive target because you can do some localized stuff or systemic stuff in both situations and get after it. Other targets that are somewhat attractive, though not nearly as effective, interleukin-2 and interferon gamma. Those are three that that this book in particular has decided to emphasize.
The major categories of drugs used for rheumatoid arthritis are going to be ones that will either downregulate pain and or inflammation, hopefully both. So NSAIDs are very, very common because of their low toxicity profile, their relative efficacy, and their anti-inflammatory capabilities. Corticosteroids, they don't really alleviate pain, but they are immune system downregulators. So if we can get after the immune system and prevent it from attacking our own tissues, that's a benefit, though there are some significant side effect profiles here. Very powerful, but again, are reserved for when NSAIDs and other disease modifiers are not as effective. And that brings us up to the DMARDs, the disease-modifying anti-rheumatic drugs. They are blocking the signal transduction and the effects of the inflammation. So things like angiogenesis and cartilage degradation and so forth. These are getting more after the specific metabolism of rheumatoid arthritis, whereas these guys are more either inflammation and or pain. So drugs like methotrexate, sulfasalazine, so forth, we'll look at a few of these. Again, I'm looking more at categories rather than individual drugs unless that drug is truly important. Originally, that was the idea, was to try to block the pain, try to block the inflammation, and if the pain continued, they might add the steroids in order to downregulate, and then eventually get the DMARDs. What's happened is, as we understand the molecular biology and the cell biology better, we're starting off with DMARDs much, much earlier than what we did the other way around. Try to head it off and get immediate cessation of the inflammatory process. And then if you do achieve a remission, then you can begin withdrawing the drugs. Again, managing the drug, or managing the disease. So the goal of someone who is presenting with symptoms consistent with rheumatoid arthritis is to achieve what we call remission, which is blocking the progression of the disease, blocking the symptoms of the disease to the point where it feels like they no longer have the disease, and sustain that remission. So there's going to be an active monitoring and active management of this, adapting the therapies, adapting the doses in order to sustain, because the remodeling and the damage that occurs during the progression of the disease is fundamentally irreversible at this point. We don't have ways of reversing the remodeling. So we're going to try to keep them in remission. If it's not working, we're going to try to keep the disease as low as possible. So if we can't achieve a full-on remission, we're going to do our best to minimize the rate of inflammation, to slow the loss of function, to keep the inflammation as low as possible. And so, because it's a chronic disease, because it requires diligence and persistence, only 1 in 5 patients can reach the 80% adherence rate. So it's a very difficult disease to keep patients on track. And that's why, in addition to all of the pharmacology, occupational therapy, physiotherapy, rest, and especially education is paramount in allowing and facilitating what we know of as ways to achieve remission. So you guys are going to be instrumental in that process. Glucocorticoids are interesting and powerful agents because they can simultaneously suppress the immune system, so downregulate immune responses, as well as the more non-specific inflammatory responses. So it's working on the sort of what we call the adaptive immunity, as well as the non-specific immunity. So it's really, really interesting and powerful agents. Because they can downregulate, like especially the inflammatory cytokines of TNF alpha, interferon gamma, and IL-1, that makes it right in the lane for rheumatoid arthritis. And it's rapid. You can inject these things right into the joints that are being affected. It will ease the inflammation, ease the pain to a certain degree, and certainly slow the rate of joint destruction. The problem is you can't just inject corticosteroids all the time into all of your joints. It will cause a number of side effects, and so it can be a little tricky. But it will allow a person to get through. So if a person is having what's called a flare, it will relieve those particularly severe things of a heart, pericarditis, which is a painful disorder, pain that radiates through the arms and legs, what's called vasculitis, and so forth. And the lead drug in all of this is prednisone. Prednisone is a glucocorticoid that is one of the frontline drugs for rheumatoid arthritis right now. Glucocorticoids, and like for instance the leading drug in glucocorticoids, which is prednisone, have all sorts of interesting and overarching effects on the immune system, and then subsequently inflammation. They are reducing the numbers and reducing the populations of those particularly pro-inflammatory white blood cells. Eosinophils, which we know are associated with anaphylaxis, mast cells, which again have lots of histamine and so forth, and they cause reduced cytokine release. They sort of act like stabilizers or something for epithelial and endothelial cells. And so forth. So there's all these interesting effects of glucocorticoids. Because prednisone does work to reduce pain and inflammation in patients and can be injected directly into the sites of inflammation and alleviate things so rapidly, it has led to some rather unusual or maybe poorly considered ways of dosing prednisone. There's certainly ways of doing what we call bridging. That is to say, if you have a patient who's beginning to show signs of rheumatoid arthritis, or if they are relapsing, and we're going to go ahead and put them on another DMARD or something, it's going to take 2-3 months, sometimes or more, for that DMARD to take effect. And so you don't want the patient to suffer during that time. So what they'll do is they'll give what's called a bridge dose in order to help stave off some of the nasty effects of pain and inflammation during that time. So they'll go on prednisone while they're waiting for the DMARD to kick in. You can do some of these bursting drugs, and you'll see probably the most well understood or the most canonical dosing other than bridge dosing is this long-term low dose. Long-term high dose is extremely problematic because of the cushingoid side effects and certainly the behavioral rage, if you will. So this is not normal, but unfortunately it does show up because again, it's sort of what I would consider the more is better effect, if you know what I mean. And so education is critical, and you guys can really help with that. So get to know rheumatoid arthritis, know how prednisone does its thing, and how it should be used, and you'll have you'll be a powerful ally in better care. If you'll do me a favor and read pages 176 and 177 for understanding the side effects of prednisone and the mitigation strategies used to minimize those side effects, I think you'll find that particularly useful information moving forward in your careers. What you have going on is that corticosteroids will drive what we call sort of a cushingoid morphology in patients. That is to say, a sort of hypothyroid, but with thinning hair, redistribution of body fat, and so forth that can be distressing to patients. There are also behavioral influences that prednisone, they call it a prednisone rage. So like this joke right here, the good news, prednisone will help you pull out of this flare. We're talking about a flare of rheumatoid arthritis, very painful and debilitating. Bad news is that your family might want to take an impromptu trip without you for the next 6 months, because there are some behavioral influences on mood and disposition with prednisone that care needs to be exercised. And the risk of osteoporosis. When you're dealing with prednisone, what you're doing is you're fundamentally shifting cell behavior. And what prednisone will do is sort of drive a more osteoclastic. It may also involve calcium regulation and vitamin D. And so there is a risk, especially with the high doses, you see a much increased risk of osteoporosis in these patients. And so weighing the advantages and disadvantages, it's certainly a powerful anti-inflammatory and immunosuppressive. You can do that sort of bridging dose that was mentioned in a couple of slides earlier. You use the corticosteroids while you're waiting for those DMARDs to really kick in. And you can inject it locally. So you can put it right into the site of where a flare might be occurring. You don't see things flaring all over the body all at once. It tends to be regional at first, and then it will sort of spread, if you will. So you can put it right where the issue is fairly precisely. It doesn't really stop the progression. It just sort of tapers or just holds off the, it slows it down but doesn't stop it. And that's where tapering was. I was subliminally channeling that word here. Is that you can't really wean them off. You can't reach remission and then wean them off. And we get that cushingoid side effect and osteopenia that leads to porosis.
Okay, so we're going to stop right there for now. In the next video in this series, we will pick up with the disease-modifying anti-rheumatoid drugs, also known as DMARDs. So I will talk to you again soon. Thank you.